Hello, ladies and gentlemen. I'm Dr. Huang Kuo-Yang from the Department of Thoracic Medicine, Changhua Christian Hospital. Today, I'm honored to have the opportunity to talk to you about how the treatment of COPD can be effectively matched between bronchodilators and pulmonary rehabilitation. In clinical practice, we often encounter patients who have used 2 or even 3 bronchodilators, but still have shortness of breath, cough, and excessive sputum. Or in outpatient clinics, patients often ask, in addition to daily use of these drugs, are there other ways to make the treatment effect even better? Through today's course, you can understand the impact and benefits of pulmonary rehabilitation treatment, what kind of patients are suitable for pulmonary rehabilitation, and how to proceed. First, let's take a look at the patient that you often encounter in outpatient clinics. This is a 77-year-old man who worked as a farmer. He used to smoke 40 cigarettes a day for 40 years. The patient came to the emergency department one day, and the main complaint was cough and progressive shortness of breath for 5 days. The emergency physician inspected the patient and found that he was breathing hard and he had a very pronounced wheezing. This is his chest X-ray. The patient has no obvious lung tumor or pleural effusion. Instead, he clearly seen emphysema on both lungs. This is a typical X-ray feature for COPD patients. And asked in detail, the patient has been diagnosed with COPD several years ago and has been used drugs in other hospitals. Therefore, emergency physicians quickly determined that the diagnosis was an acute exacerbation of COPD and give non-invasive positive pressure ventilator treatment. This is the report of the patient's subsequent lung function test. It can be clearly seen that the patient's FEV1/FVC is 52% before and 48% after inhaling the bronchodilators. As long as FEV1/FVC is less than 70%, it means obstructive respiratory disease. In addition, the patient's FEV1 did not improve significantly before and after the bronchodilator was used. The FEV1 was only about 600 to 700 milliliter, which was only 25 to 28%. This is a typical result of lung function test in COPD patients. This is the diagnosis and treatment guideline recommended by the COPD Gold Guideline. When the patient's lung function shows obvious obstructive of inhalation, that is, FEV1/FVC is less than 70%, COPD is diagnosed. Everyone should know that the GOLD guideline has been treating COPD patients since 2017 and is no longer solely based on the level of FEV1 in lung function to determine how to use or choose drugs. Instead, it is divided into 4 groups based on the patient's symptom and the risk of acute exacerbation. According to the recommendation of the GOLD guideline, we can use MMRC score of 0 to 1 or greater than 2 as the cut point according to the patient's symptom, or use CAT score of less than 10 or greater than 10 as the cut-off point. In addition, Y-axis is distinguished by the frequency of acute attack in the past year. It can be divided into 4 groups, A, B, C, and D. Among them, Group A has fewer symptoms and the lowest risk of worsening. Group B has more symptoms and a low risk of worsening. Group C has fewer symptoms and a higher risk of worsening. Finally, Group D is the most severe group with more symptoms and a higher risk of worsening. There are different medication recommendations according to different groups. In Group A, only short-acting bronchodilators are needed. Group B or C, this is to consider using LABA, long-acting beta-agonist, or LAMA, long-acting muscarinic antagonist alone. However, for Group D, with many symptoms and a higher risk of worsening, it is a recommendation to use inhaled corticosteroid in addition to the combination of LABA and LAMA. The final diagnosis of this patient was COPD Gold 4 Group D. Triple therapy was used for treatment, and LABA, LAMA, and ICS was given at the same time. There are many changes in caring for COPD patients on the front line. At medical end, we are faced with insufficient time, the inability to detect potentially high-risk patients, and inexperience in judging lung function reports. Also, on the patient side, because our health education is not enough, patients do not understand the cause and symptoms of COPD and therefore delay seeking treatment. These various problems are obstacle to our diagnosis of COPD. In an analysis of National Institute of Health in USA, funding for research into specific disease, disability-adjusted life years, DALYs, was shown to be the best predictor of research funding allocation. The disability-adjusted life years, DALY, is a measure of overall disease burden, expressed as the number of years lost due to ill health, disability, or early death. It was developed in the 1990s as a way of comparing the overall health and life expectancy of different countries. The DALY is becoming increasingly common in the field of public health and health impact assessment. It not only includes the potential year of life lost due to premature death, but also includes equivalent year of health life lost by virtue of being in status of poor health or disability. However, for COPD, actual research funding falls far short of the funding predicted on the basis of DALYs. Compared with other chronic diseases, example heart disease and diabetes, COPD received far less research funding than its attributed mortality warrants. COPD is the third leading cause of death in the USA, but the 14th most funded research category at the NIH. In the past, we have always focused on the drug treatment of COPD. What patients often care about most is there a better or new drug that can have a better effect? However, for COPD patients, in addition to drug treatment, we have a very simple method of pulmonary rehabilitation coupled with non-drug treatment, which can improve the patient's symptoms and improve the quality of life. So, what exactly is pulmonary rehabilitation? Pulmonary rehabilitation is a broad therapeutic concept. It is defined a comprehensive intervention based on the thorough patient assessment, followed by patient-tailored therapy that includes exercise training, education, and behavior change, designed to improve the physical and psychological condition of patients with chronic respiratory disease and to promote the long-term adherence to health-enhancing behavior. In this practice, we can see our expenditure on the treatment of COPD patients. At the bottom are cigarette seasons and flu shots, which are the cheapest. Then we see the part of drug treatment. In fact, COPD treatment is very expensive. However, the cost of our pulmonary rehabilitation is only one half of the use of medicines, which can improve the symptoms of the patient. This is evidence that self-management intervention will be effective if the patients are properly supported and embedded in wider chronic disease management program. For example, pulmonary rehabilitation and support self-management are key components of such programs. How long does the course of pulmonary rehabilitation take to get the effect? Here are 4 options for you. 1. 4 weeks. 2. 8 weeks. 3. 12 weeks. 4. 1.5 years. Before our course goes on, everyone can think about the answer in your mind. In fact, according to the meta-analysis article published in the journal Respirology in 2017, it can be seen that compared to the usual care, whether it is upper 8 weeks or the lower 12 weeks of pulmonary rehabilitation treatment, obvious benefit can be seen in the 6-minute walk test. So, in fact, it only takes 8 to 12 weeks to see the effect of pulmonary rehabilitation. Would it be better if we lengthen the time and continue to recover the lungs? This was a multi-center prospective randomized control trial including 143 patients with moderate severe COPD with 3 years of pulmonary rehabilitation maintenance followed by an 8 weeks outpatient pulmonary rehabilitation program. Patients were randomized to maintenance intervention group and standard monitor program or control groups. We can see that as the time of recovery of this stretch to 2 or even 3 years, the effects of the intervention group become less and less significant. In other words, pulmonary rehabilitation therapy will have an effect in a short period of 8 to 12 weeks. But if it lasts for more than 2 years, the effect will gradually become insignificant. So back to our question, how long is the more appropriate pulmonary rehabilitation treatment? The answer is obvious. Therefore, according to the recommendation of the GOLD guideline, pulmonary rehabilitation is best for 6 to 8 weeks, twice a week for the best results. Let me introduce the 3 types of pulmonary rehabilitation treatment we often do in our hospital in Taiwan. Patients with lung disease may have a rapid, shallow breathing pattern, and it is so that rapid, shallow breathing is deleterious to ventilation and gas exchange due to the potential increase in dead space ventilation and progressive air trapping. Retraining with breath technique that decrease breathing frequency, such as pursed lip breathing, has in some studies led to increase in tidal volume and oxygen saturation and a reduction in dyspnea. Negative pressure ventilation is a more natural way of breathing physiology. In general use, short-term or intermittent mechanical ventilation is used to assess the expansion of lungs, help to clear the respiratory tract sputum, and allow the respiratory muscle to relax and rest appropriately. Most of our knowledge about exercise conditioning is derived from programs emphasizing leg training. This is unfortunate because the performance of many everyday tasks require the use of hands plus the concert action of other muscle groups that are used in upper torso or arm positioning. Some of these muscle groups serve as dual function, respiratory and posture, and the use of muscle for arms exercising decrease their capacity and participate in ventilation. Arm training results in improved performance, which is mostly task-specific. The three main aspects of pulmonary rehabilitation therapy can improve patients, namely shortness of breath, health status, and exercise tolerance. In four important domains of quality of life, including dyspnea, fatigue, emotional function, and mastery. Pulmonary rehabilitation, dyspnea, can be significantly improved in this project. People who have pulmonary rehabilitation have reduced the symptom of dyspnea by about 20%. Statistically significant improvements were noted in all domains of the St. George Respiratory Questionnaire (SGRQ), and improvement in total score was better than 4 units. Pulmonary rehabilitation can significantly improve exercise performance, and the degree of improvement is higher than the smallest importance. Pulmonary rehabilitation is not only improved in patients' shortness of breath, health status, and exercise tolerance. Randomized control trials, RCTs, comparing pulmonary rehabilitation of any duration after exacerbation of COPD versus conventional care. Pulmonary rehabilitation can also reduce a rehospitalization rate by about 56% and the mortality rate by about 32%. Pulmonary rehabilitation not only improves respiratory symptoms, but also helps COPD patients with external symptoms. In particular, pulmonary rehabilitation can improve patients' anxiety and depression. Compared with usual care, pulmonary rehabilitation confers significant benefits of a moderate magnitude for anxiety symptoms and a large magnitude for depression symptoms. Finally, I share the two most important aspects of pulmonary rehabilitation for first-line care. First, we must find a patient group that has the best effect on pulmonary rehabilitation. That is, patients in GO guideline group B or C. And let this group of patients be able to receive a complete pulmonary rehabilitation treatment so as to maximize the patient's improvement. However, it is difficult for family members to bring patients to the hospital for pulmonary rehabilitation treatment every time. Family members may have the following three facts. For example, geographically factor. The home is too far away from the hospital. Traffic factor. Family member cannot transport the patient to the hospital for treatment. Economic factor. Family members do not have extra money to allow patients to receive treatment. Although there are so many difficulties in pulmonary rehabilitation compared with COPD drug treatment, pulmonary rehabilitation has an absolutely irreplaceable part, that is, through our interaction with the patient can feel our care for him and the enthusiasm for medical care. This is something cold medicine cannot pass, and this is the most important mission of our medical staff. My report is here. Thank you very much for participating in my speech. I'm Dr. Huang Kuo-Yang in the Department of Thoracic Medicine, Changhua Christian Hospital. I wish you all have a good day.